Across Canada, more than 1,300 people have died with medical assistance since that option became law almost a year ago. According to numbers obtained by CBC, current as of the end of March, 21 of those deaths were here in Saskatchewan. Dr. Carmen Johnson is Medical Director of Palliative Care at Regina's Pasqua Hospital. She has assisted in some of those cases, and she's in our Regina studio. Good morning.
Good morning.
So tell me about the first conversation. How does it begin? Once someone has decided and they're at peace with their decision, what happens then? What does that conversation look like?
Well, a lot of things happen even before that conversation, and I just like to frame it discussing end of life in general. So, first of all, there's everybody's heard of palliative care, and I'd like to discuss the role of palliative care in these types of situations. There are a lot of misconceptions about palliative care out there, and palliative care isn't just about dying; it's about living well until you can't. And palliative care has become more of a philosophy rather than just something that people do at end of life, and it looks at the whole person. It involves the whole family, and it's something that physicians are trained in when they're doing medicine, and it's also provided in the primary healthcare system. And people can be palliated for their disease for many years. The word palliate means to ease symptoms without necessarily removing the cause. And many diseases in medicine, as you know, are incurable. Congestive heart failure, COPD, neuromuscular disorders, and of course, cancer. So palliative care doesn't have any specific age group, no specific diagnosis, and again, it's not necessarily about end of life. Our palliative physicians are often even involved in cases where curative intent is part of the goal for care, such as some cancers, and we help with symptom management in the meantime. So initially when palliative care started, it was just surrounding end of life, but that has changed. And actually, I think that now that medical assistance in dying is here, it's a good thing for palliative care because people are talking about what's really important to them and about end-of-life issues. So here in the region, I've asked that people who are requesting more information about medical assistance in dying have an assessment with a palliative care physician. And it's not that we're going to try to coerce them out of this decision. We just want to give them good information surrounding their options. There's so many misconceptions out there in the public and even amongst the medical community as to what we can offer for palliative care. So that was why I asked that happen. Now, certainly that does not have to happen. It's just one other physician and then the person who does the procedure.
What's that physician looking for? Are they looking for real clarity from the patient? What are they looking for when they do that assessment?
Well, you look at the patient's situation. You look at where they are in their disease process. Are there symptoms that could be palliated in the meantime? We try to tease out, is this patient under duress by other family members?
That must be tricky sometimes. You know, I'm thinking, for example, if you have maybe a man who has cancer and he's terminal and he wants to make life easier for his wife, it's not necessarily coercion,
No.
but he's not doing it for the right reasons.
Everybody has their own reasons, and what we do is make sure that they meet criteria and have all the information.
So what are the main criteria?
Well, I have them here. I'll just go over them quickly. First of all, you have to be eligible for services within Canada. So somebody from the United States can't come up here and request medical assistance in dying. It gets rid of the medical tourism. They have to be 18 years of age, and they have to be mentally competent. And then the condition they have is described as grievous and irremediable, which mainly says they have a serious disease or disability and they're in an advanced state of decline, and that rate of decline cannot be reversed. They're suffering unbearably from an illness, disease, disability, or state of decline, and be at a point where their natural death has become reasonably foreseeable.
Is it usually cancer?
For the most part, it has been cancer. One of the things that's also in this criteria is suffering unbearably. And it isn't the physician who determines how a patient is suffering, because suffering has so many faces. We have to believe the patient that this is not a way that they want to live anymore.
Yeah. And that sort of gets to the concern that some people had going into this legislation, seeing it as a failure of palliative care. If a patient is suffering unbearably, that means they need better pain management. And how do you respond to people who say that?
A lot of the patients that we see who are requesting medical assistance in dying do not actually have any symptoms that need to be palliated. If they do, then we palliate them until they have the procedure. Sometimes the patients will have good symptom control and then decide that, okay, this isn't unbearable, but I still have the information, I know my options, and I feel good about that, and then they delay.
And what about the final decision? Can the patient be turned down?
Yes, they have to meet the criteria.
Okay.
And they have to be able to give consent right until the very end, before they either take the medications by mouth or have the injection.
So it's either medication by mouth or injection.
Yes.
And the approval of two physicians?
Yeah, two physicians have to say, yes, this person meets criteria.
Do you talk with family members as well as part of the? Is that always a part of the process?
It isn't always a part of the process. The patient is the director of their care. Certainly we encourage them to talk to their family members because it can bring about certainly complicated grief, bereavement afterwards. And as part of a palliative approach, we treat the family as well as the patient, and we're there to help facilitate those discussions as they come.
What does it mean to you personally to help give people a good death? If you determine they've met all the criterias and they're at peace with their decision, what does it mean to you personally to be able to take them where they want to go?
Okay. Well, what is a good death? I don't know if there's such a thing as a good death. Usually it's a very difficult time of life. It's a very meaningful time of life. And we all want to die with dignity. Now, palliative care claims that it helps people die with dignity. And the proponents for medical assistance in dying say they help people die with dignity. And a person's dignity is determined by what that person believes. And so I have a passion about helping people during these troubled times in their life. It's very rewarding. It's very, very meaningful. Now, before the medical assistance in dying was available, it was very heartbreaking to have patients who really wanted to have medical assistance in dying. It wasn't ready yet. They felt that they were undignified. Many people don't want to go through the frailty and the process of the dying process because you're very vulnerable. You can't necessarily speak for yourself. You may be very weak, and it's just such a difficult time. Certainly with palliative care, we work towards treating symptoms aggressively and supporting the patient and the family during the dying process. I tell them that we're their guide. None of us have done this personally before. It's not something you can practice like playing softball or get better at it. But we've walked with many people through this process before, and we tell them what's happening, and we give them good information.
Thank you so much. It's such an important thing to be talking about, and I really appreciate you taking the time to come in and talk with us about it.
Okay, thank you.
That's Dr. Carmen Johnson. She is Medical Director of Palliative Care at Regina's Pasqua Hospital. Again, since the law was passed across Canada, more than 1,300 people have died with medical assistance. As of the end of March, 21 of those people were in Saskatchewan.